Well, unfortunately, most of my talk has been given by everybody else over the day. And when I said that to someone at lunchtime, they said reiteration and memory stimulation will be good. So I do apologise because a lot of it has happened before. I was emailing Kerry desperately last weekend when I was trying to write this talk because unfortunately, from my perspective in Australia, there's very little happening, and the list was very short. And I was so desperate, I actually left off one of the major Australian trials. So I'll try and tell you about that as I go on. How are new treatments developed? Kerry's really gone through most of that. There's been rapid advances in molecular biology, which have allowed scientists to compare the differences between normal and malignant cells. These genetics control growth, cell division, movement of cells through an environment, and also how they actually interact with their environment and how they interact with their immune system. The first human genome project was commissioned by the US government. It cost $3.8 billion and actually took 13 years to complete. And now we have technology that can do something like this in a couple of months, but it still costs 10 to 20,000. So the machines are expensive, but the cost is coming down the more and more we do it. With this new technology, as you saw with the identification of isocitrate dehydrogenase or IDH, different things that we never even thought of have been discovered and are providing us with more targets and more drug development targets, but also to explain some of the environmental changes around a tumour that we also may be able to attack. So the molecular biology is, as Kerry said, watch this space, explosive. This is what a gene sequencer looks like, and if you have enough money to buy a bank of gene sequencers like this, you then have to pay about 100 bioinformaticians to analyse all the data that this machine will spit out. So you can actually send off your sample and ask for the genomic profile of your tumour and then wait for 3 months while some very clever mathematics person comes back to you and says this is significant or this isn't. And then you can't interpret if you're someone like me. So I go back to the textbook and say, oh, anyway. We can map pathways that are unique to different cancer cells, and as Kerry also explained, a glioblastoma is not a glioblastoma. There is at least 4 different subtypes, if not more. These are the kind of cartoons of some of the pathways that you can see, identifying multiple different genes becoming abnormal. Some genes are overexpressed on the surface of cells and make potential targets for antibodies and other therapies. One of the maybe good things about glioma, if you track how many gene mutations in a cancer, the cancer with the lowest number of mutations is something like leukemia or lymphoma. The ones with the highest are those in lung cancers in smokers and melanoma. And then really close to leukemia and lymphoma are glioblastomas. So even though we call these things glioblastomas, and we talk about them being incredibly unstable and having all these gene mutations, to me that's a kind of bit of hope that we're dealing with about 30 gene mutations per glioma cell, where you're dealing with 160 in a lung cancer cell. So targeted therapy may have a better chance in something like glioma than it will in some of these other solid tumours. Kerry showed you this thing called a heat map, which identifies different genes that are upregulated and downregulated in low-grade, high-grade, and also between the different grade 4 tumours. There's Kerry's slide, so I'll just keep clicking on that. So the overall thing we want to do is destroy cancer cells and leave the person intact. Obviously, surgery, we want to physically remove as much as we possibly can. Radiotherapy, laser therapy, cryotherapy can actually kill cells. Chemo poisons out the malignant cells. We're looking for targeted therapies which will block some of those pathways that these particular cells are using to divide and move. And another way of attacking them is to make the environment in which they're living hostile. So it's a bit like if you don't water your plants, they will die. No water, no hydrangea. If your cancers are living in an environment, they need to interact with blood vessels and other cells in their environment. They need to anchor down. They can't just float willy-nilly through the bloodstream. So if we can make the environment hostile, potentially, excuse me, I'm just going to, can I just grab a glass of soda? I really dry mouth. Oh, thank you. I shouldn't be nervous. I shouldn't have a dry mouth. Thank you. So another area to attack is the soil in which these are living. And if I take a cancer out of someone and I grind it up in a test tube and I get the cancer cells and I give it as an IV injection, those cancer cells won't survive. So they've been taken out of their environment, they can float through the livers, they can float through the lungs, and because they've been taken out of the environment, they just will not survive. So cancer is not contagious, unlike what some people believe. And another way of attacking them is to activate the immune system to directly attack the baddies. There are a number of different kinds of clinical trials evaluating new treatment therapies. One of the things that I'll go into a little bit is epidemiological genomic studies trying to look for associations as to why people get gliomas. There are quality of life trials. What symptoms do people suffer from and how can we best alleviate these symptoms? What medications work, what don't work? And obviously the terrible drug in our armamentarium is dexamethasone. We all love it because people can come in unconscious and they can wake up 4 or 5 hours later. We hate it because of the long-term side effects it causes. And other things that we're looking at is the impact of what does caring for someone with a brain tumour do to the family and the carers. And that is an enormous problem. It's a 24/7 plus job. When people's personalities are changed, you're not living with the same person anymore, the stress on the carers is enormous. And in fact, a study from Western Australia we were involved in showed that the carers are under twice as much stress as the patients. So studies don't just involve drugs, they involve a number of different things. There are a number of different agents being developed to allow surgeons to identify malignant cells at the time of operation. We heard Brenda talk about something called ALA, and there's something else that's quite exciting called tumour paint. And this ALA is good for identifying high-grade tumours, but tumour paint may also identify lower-grade tumours because we really want to see the infiltrating margin of a low-grade tumour and try and remove it because there is just a possibility that if the surgeon can get out all a low-grade tumour, they may be cured. And this came up from something in third world countries that they realised that if you paint women's cervixes with vinegar, the little old nurses in those country clinics can actually determine whether there's cervical cancer sitting on the cervix or not with very simple tortures. So that was a study that was sponsored by the Bill Gates Society and is now being used all through Africa and Asia to try and pick up cervical cancer early in these patients and treat them early because it's a huge plague and it's very disabling. So neurosurgeons are not putting vinegar into people's heads. These are very complex drugs, but we're certainly allowing things to happen at the surgical base. You can see that if the surgeon's looking down a microscope, he sees something like this, he thinks he's taken it all out. And if someone's had this ALA and there's still a bit of residual stuff left behind, you can see these bright pink dots. And that is evidence of residual high-grade tumour that he would then go back and remove, even though just visually he hasn't got it all. New therapy trials. Why bother doing clinical trials? It's a question, and especially if you've been asked to go on a randomised placebo-controlled trial as a patient, you would really question why we're doing this. But we really need to test the safety and efficacy of new drugs and new devices. While we can initially develop most things in test tubes, animal models, it's not that they're actually introduced into humans and human clinical trials that we can determine the efficacy and the side effects of these drugs. So, as I said, tumours only survive if they have a friendly environment, they're parasitic, but only 1 in 10,000 drugs that looks good at benchside will make it into the clinic. So there's an enormous wastage along the way from things that look incredibly promising. There was a thalidomide disaster. I actually did a trial in brain tumours with thalidomide once. But all the preclinical testing in thalidomide was done very safely, looked like a very promising drug, very, very safe sleeping tablet. It was introduced into the clinic. Unfortunately, the preclinical stuff was not done in white New Zealand rabbits. Now, white New Zealand rabbits metabolize thalidomide the same way as humans do and break down one of the components into a toxin which affects unborn babies. But rodents and dogs and other animals don't. So this drug went into clinic with all the preclinical testing, and it wasn't till someone's secretary noticed that he was following up a whole lot of babies with no arms and legs that there might have been a problem. Because, you know, if you're a woman with morning sickness, you must be neurotic and need a calmer downer. So there was a lot of thalidomide being handed out to women with morning sickness. Kerry said drugs are initially developed and evaluated in test tubes. They then go into animal models, and they then make their way into clinical trial. And the cost of one drug from benchside into the regulators to say that the government will say this is a good thing to do for people is estimated now to be $1.7 million. So this takes account of all the things that have failed along the way that they've invested in. And one of the problems I was involved in not so long ago was the fact that for every 20 drugs that we take to the Australian government with very good evidence that this is very effective treatment for people with cancer, and it's not just glioma, the TGA is saying, yes, we agree with all the data, this is a really good thing to do for people, only one goes onto the PBS. So we have 19 drugs sitting in Australia that could be useful for other kinds of cancer treatment, not funded. And the cost of most new drugs coming into the clinic is somewhere between $5,000 and $10,000 a month. So if you want it, you've got to be a millionaire. How the trials were initiated, the lab develops a new compound. Most smaller biotech labs cannot afford the $1.7 billion. So after some preclinical testing and some early clinical trials, they usually on-sell this to one of the big pharmas. Different trial units are asked to do different kinds of trials. The early phase testing is usually done just in Europe and the US and occasionally in Australia. Royal Melbourne in Australia has a phase 1 early trials unit up and running. But phase 1 trials are very hard to get onto. And if you're on an early phase trial, we know that A, we're testing for toxicity, and B, we have no evidence about efficacy. So scrambling to get on to a phase 1 trial, it's a good step along your treatment pathway. They're very hard to get onto, and it may be pretty early. Different centres around Australia have different trials open at different times. So not every centre has every trial at any one time. And for a patient trying to find what clinical trials might be open and relevant to them, it's not an easy task. I don't know what Brisbane are doing, and sometimes we do. There's 2 recommended websites, but I actually went down there and Googled what clinical trials are open for neuro-oncology, and the top clinical, one of them came up with ZIT. So you can ask your care coordinators if they know anything, you can ask the state cancer councils if they know anything. And the worst thing I find is the patient that comes in and says to me, my cousin saw this on TV last night and it's a new drug for brain tumours and can I have it? And when you ask, what station was he watching? Who was presenting, any names, numbers, I mean, I don't watch telly, I don't have time. It's no. So if anyone sees something very interesting on a TV show or reads it in a paper and you want to ask your doctor about it, please write down the name of it, please cut it out. And I mean, most of us will really do our best to find out what's going on. But on the other hand, when my cousin from Burke saw something yesterday in France, it doesn't help much. The next question is, the next request is, I want to go to America. They got so much better than we have. And most drugs are often first tested in the big US hospitals. Most drug trials are undertaken on people with relapsed grade 4 tumours. At that stage, most patients are not that well and they're not that stable. And getting on a long-haul flight to the States is not that much of a good idea. The financial cost of going to the US is enormous. You've got the airfares, accommodation. You need a medical visa, which when I last checked was over $150,000. It has to be deposited with the American government before they'll issue you with a medical visa. And then you've really got to think about the emotional cost of being away from family and friends. And most of these things, if they do pass early phase, will come internationally anyway because they want to recruit as many patients as possible. Phase 1 trials look at first in humans, looking for side effects, and come up after extensive animal testing. Usually they take 3 patients at one level, and if they do okay, they'll take the next 3 patients and the next 3 patients. And you really need to be sitting next to the hospital at the time to be one of those 3 patients at one of those levels, because these 3 patients will be maybe monitored for 2 months and you just don't know when the next cohort is going to open. So that's a pretty difficult process for people with relapsed high-grade tumours. Phase 2, safety. We think we've got the right levels in humans, and then we take a particular disease and we test the drug in a cohort of patients with the same disease, looking for, does it work and is it safe? If that's promising, they go into phase 3 trials comparing the normal standard of care with something new. So why would you want to do a randomised phase 3 trial? I mean, they're a pain in the neck. They take about 5 years to recruit. They cost the drug companies billions. But one of the problems with phase 2 trials is if you take the grannies from the nursing home and test 20 patients on one side of your trial, or you take the 1939 English rugby team and test them on a trial, you are naturally going to get different results. So until you actually randomise these patients, you're going to have there's a number of factors that could lead to an outstanding result, which is not a true reflection of what we're doing. So the endpoints are, is the new treatment better? Is there any more side effects? Is the side effects worth the cost of the drug? Their cost, health economics, which will determine whether it makes it in Australia to the PBS. And the next problem is the cost to the family and the impact on quality of life. Maybe some increased side effects and maybe increased time in clinic. If you're on a trial, you have to come in for more blood tests, more reviews, more scans, more everythings. So as I said, there are very strict entry criteria. So just because you've got a relapsed GBM doesn't mean you're going to go on a clinical trial. You need to have certain criteria that are met. The challenges of phase 3 testing for all companies is the cost, the large number of patients we need to detect a difference. And there's a big effort in the neuro-oncology world at the moment to have a different endpoint. So instead of having to put 400 patients on one side of your trial and another 400 patients on the other side of the trial and wait for 3 years to recruit your 800 patients and then wait for another 4 years to get the result, there may be some different endpoints that we can look at to say this is good or this is not. If we do find that, which would be great for us and great for patients, we then have to convince governments that this is not level 1 evidence, but they should still approve the drug on the basis of different endpoints rather than their beautiful, clean, randomised, placebo-controlled trials. So there's a lot of steps along the way, but it's going to need to happen in glioma. There's advantages to being on a trial. You may get access to some great new drug, and you're certainly very closely monitored by a research team. Disadvantages, lots of extra visits, etc. There have been trials in anti-angiogenic therapy, blocking the blood vessels, making the background inaccessible, blocking the glue that the cancer cells stick to the environment with, and harnessing the immune system. There have been breakthroughs, as you've heard already, in melanoma and prostate cancer with immunotherapies. And studies have revealed, however, the cancer cells are pretty tricky, because if they were lying out there in the open and able to be attacked, they wouldn't be there. So they secrete hormones that get new cells out of the bone marrow, go up and surround them, form a new population of immune cells called marrow-derived suppressor cells. And these immune cells are sitting next to the cancer cells and buzzing away anything that wants to come and attack them. So not only do we have to boost the immune system, we actually have to get rid of the suppressor cells so that the new targeted therapies and immune therapies can get a go at the cancers. So it's much more complex than we thought about. This is just a picture I borrowed from someone, and you can see this is colon cancer, and in C are immune cells sitting next to the colon cancer having a really good look at the cancer cells, protecting it. This is high-grade colon cancer, and it's full of immune cells. And I call them tumour-impotent lymphocytes, because they're sitting there and they're doing nothing at all that we want them to do. So for immunotherapy, we need a target. Specifically, something called epidermal growth factor variant 3 has been identified, and there is a randomised trial looking at a vaccine against that in Australia called ACT4. There's at least 10 sites open in Australia, comparing standard chemoradiotherapy for grade 4s plus or minus the vaccine. You've heard from Kerry about dendritic cells. Basically, they put you two big cannulas, one in either arm, suck blood out one side, put it through a spinning machine and put it back in and siphon out primitive dendritic cells, take them to the lab, grow them up, stimulate them, expose them to what you want to attack, and then re-inject them back into patients. So that's the basis of the Oslo story, something called DC-VAX, the CMV trial that was going on in Brisbane. But so far, it's enormously expensive at the moment, and as Kerry says, we haven't had any great results. A current study that's already been mentioned that anyone diagnosed after the 1st of August 2013 can participate in is taking a very full history of where did you live, where did you grow up, did you have chickenpox, and a blood sample from the patient and a first-degree relative that will all go into this big mishmash of at least 800 Australian patients, be matched up with some US, and see if there's anything genomic or environmental that we can pick to work out why this happened, why these tumours occur. That's it. Thank you.